I welcome you all, and I think we have some folks who are joining us online. Thank you for joining this panel. I'm Upendra Bhojani. I work at Institute of Public Health, Bangalore, and it's very special to come to IIHS. In fact, I had a privilege to work here, even though for a brief while. Um, and so, just briefly telling you about this panel today and the format. I'm joined by some of the wonderful panelists who are public health experts who come from different disciplines. And through the panel, we'll attempt to deliberate on how various transitions that I think many of you have been deliberating in the last 2.5 days of the urban arc in relation to health systems. Now, in public health, we understand health as a state of well being, which is not just about physical health, but about physical, mental, and social health. And in that sense, we talk about population level health, we talk about health inequities, the unfair differences in health across social groups. And when we think that way, we can think about health as not just being shaped by biological or genetic factors. I think sometimes those are more visible when you look at physical picture of health systems, right? The hospitals, ambulance, etc. But the health is, if not equally, more dominantly shaped by social, economic, political, cultural factors that we refer to as social determinants of health. In that sense, health systems, like many other public systems, are social systems. They are embedded in society, in the larger realities of society. So various transitions that we are deliberating here, they shape health systems as much. And so I think through the panel, we'll try to unpick some of these transitions. And maybe I'll start with my colleague Vaibhav. So Vaibhav is a medical doctor who worked who practiced medicine and also chose to work in shaping community health initiatives in different parts of India, particularly working with NGOs in Maharashtra, Chhattisgarh, basically Adivasi districts of India, and later on got trained in epidemiology before joining me as a colleague at the Institute of Public Health, Bangalore. So I think while we'll touch upon various transitions over time, I think one of the transition um, which is inevitable and which is probably more directly impacting health systems in India today is how illness profiles are changing in our society, right? And what we call epidemiologic transition. So I think, Vaibhav, why don't you help us better understand what is this transition and what are the implications of such transition on health systems in urban areas? Yeah, over to you.
Yeah, so I'll briefly talk about epidemiological transitions within India and then tie it to urban health systems before I hand it over to my other panelists. So let's have a quick look at this table first, which showcases how top 10 causes of death in India have shifted over a decade. Broadly, if you see, they are still can be categorized in two broad categories: communicable diseases, which are infectious diseases primarily, and non-communicable diseases, which are diseases which are not communicated but have a wide variety of causes which lead to their existence. Um, but these two categories are still major buckets. And the second table on the right hand also sort of showcases their overall contribution to the mortality in India in year 2021. At the same time, please also, it's important to mention injuries is also emerging as another bucket of sort of uh, major cause over a period, which is likely to grow in future. So these are the broadly two major transitions that are happening. Briefly, in case it helps, sort of what are epidemiological transitions? These are basically just changes in patterns of mortality over a period of time. Also important is the fact that multimodality morbidity is also happening at the same time. There have been several studies which say somewhere between 88 to 33% of adults have multimorbidity. That means they have more than one chronic disease at the same time, which is also important to note. This table shows the changes in the patterns of the risk factors which underlie these diseases, whether communicable or non-communicable. And again, there has been changes in the way what are the top causes, but again, broadly, it reflects the same mortality table, that they are also the major risk factors in India, within India. Another transition which is very closely related to is the demographic transition. Currently we are a very young country in terms of population age, but soon it is going to change, and we are going to become aging population within a few decades, just to keep that in mind. Now, I'll briefly talk about how urban health systems have shaped in India, or developed in India over a long period of time. I won't be able to go in detail, but very, very briefly, as we became independent, primary healthcare was the major focus within India. For example, Bohr Committee, which highlighted that primary healthcare should be the major sort of foundation to organize our healthcare, which continued. But within primary healthcare also, selective primary healthcare was the focus. That means not everything, all services were able to be covered. Then comes liberalization era, where private healthcare became a reality within India, which grew, which is growing rapidly, but it stays prominently centered within urban spaces within India, which is now currently a major player of care provider in urban spaces. Then came National Rural Health Mission in 2005, which said, let's sort of put a lot more resources to revamp the healthcare organization, infrastructure, etc. And then around 2010-12 came recognition that we also need to take care of urban health. So came National Urban Health Mission, which was of course sort of focused, or maybe sort of impacted by larger global policies, discussions, etc., etc. And very recently, the Ayushman Bharat program, which focuses on 1.5 lakh health and wellness centers, which goes beyond selective primary healthcare. So this is how urban health systems have come, I mean, sort of developed over a period. I'll briefly touch how the epidemiologic transitions have sort of create challenges for the urban health systems. It's sort of underfunded health system that we have, and I'll just maybe highlight one example. So chronic diseases which are now dominating in India require long-term care, requires organization of care in such a way that there is continuity of care. Uh, and needs a lot more resources, including human resources. So it strains our current service delivery model, which is episodic sort of model based on communicable disease patterns. That is just one example to sort of highlight. And I'll hand it over back to Upen.
Thank you, Vaibhav. So I think you highlight how there is this rising burden of non-communicable diseases, and also the aging population, and all of that have a very different type of care demands for which our health systems are not really ready. And you also briefly highlight how health systems are in constant flux, not just by the local circumstances, but by even what is happening globally in terms of economic reforms and other things. So that brings us to the health system per se, then, and the healthcare delivery systems in urban areas. And you are saying that it's much later that we woke up to the systemic challenges in urban health systems. Maybe my crude assessment is that if one has to really rely only on government healthcare system at primary level, maybe a rural Indian is much better off than in urban India, which is really an irony. But anyway, I think even when we talk about healthcare systems, The thing is that not everybody has an equal access to these healthcare delivery systems, right? And that's where I think I would like to maybe invite Sudha. Sudha has joined us online from Mumbai and has smartly avoided all the traffic hurdles that many of us had to wade through to come here. Uh, Sudha is a very good friend and an excellent health policy and system scientist. Did her PhD from TIS Mumbai and has been working for several years researching, the healthcare access, especially among urban communities. So, Sudha, over to you, Sudha. If you can highlight what are the challenges when it comes to accessing, the healthcare systems in urban areas.
Thanks so much, Upin. I thank you especially for the great introduction, and it's really nice to be with you all today evening and avoid the Bangalore traffic. So please bear with me as I join online. So as Upin said, maybe we can move on to the next slide. I don't have, yeah. Um, so what I'm going to do is what Vaibhav had told us was he sort of presented the overall context of a broad picture of what is happening with the epidemiological transition and how what our health systems are facing because of that. So now I'm moving a little more micro level. I'm focusing on one subsection of the urban population which sort of lives in urban informal settlements or slums as we um, call them. Okay, how are these groups managing these transitions that we've been talking about? How are these groups accessing healthcare? And what sort of challenges do they face? Do these populations face when they need to access healthcare in particular? So, I think these are some of the important context, important questions also in today's context. And what I'm going to try and do is, could somebody just shift to the next slide? Yeah. So I'm going to try and illustrate some of these issues using a very short, stitched in case study. And this case study is from one of our uh, uh, recent sort of work. So this story is of Radhika, whose name has been changed. She's 32 years old, a mother of three. She lives in an urban informal settlement in the outskirts of Mumbai. Okay, she had a cut in her hand while chopping vegetables, but this cut did not heal. So she went to her family doctor, as she calls it, who gave her several ointments, but still the cut did not heal. Okay. Her husband, now seeing her inability, her struggle with household chores, took her to a private skin specialist now. This specialist was recommended by the owner of the loom mill where he worked. So and regarded as very expensive but very good. Okay, so it was the skin specialist who ultimately diagnosed and prescribed medicines for diabetes for her. Okay, 2 months later, Radhika started feeling better. She reduced. Then what she did was she reduced the prescribed dosage to half in order to save money. Her husband's hours at work at the mill had also been cut down after COVID, the lockdown. So the family had to cut costs. But then she started feeling tired again. She went back to her family doctor who advised her to get medicines from what she calls the big Bada Hospital, the big public hospital, which is in the main city. She went there once with her sister in law. Her sister in law could speak Marathi, she couldn't, and she got her medicines. But then she couldn't go for a second refill due to childcare responsibilities. Okay, so this case can give us a lot to ponder about. So I've put like some of the points in the black boxes here. If you look at the first paragraph in Radhika's story, right, we see that the first place she goes to, the very first access for her to the health system is somebody whom she calls as a family doctor. Okay. Usually in these contexts, the family doctor is very different from what we imagine. These doctors don't have an allopathic degree, an MBBS degree. They have sometimes they have alternate qualifications, but which doesn't match the kind of treatment they give, or they advertise qualifications which have no value at all. Okay, it is these doctors who are the first contact points for healthcare for people living in these informal settlements. These doctors provide these small medicines. They charge fees which the community can afford. Okay. However, as we go, if we go to the next part of the story, we see that these doctors do have their limitations. So there are some doctors who are able to diagnose much better, but this particular family doctor in this case could not link the delayed wound healing with diabetes, and it took, in fact, a specialist to get to a diagnosis, and they had to spend a lot of money for that. So this brings us back to the paradox that Upen was talking about. Okay, so we always, when we look at national level data, we've been told time and again, doctors are concentrated in urban areas. It's the rural areas that lack doctors, but just having qualified doctors in the vicinity is not a guarantor of access. Okay? In fact, like Upen had said, we often find people in urban slums, they only reach out to qualified providers when the informal sector fails them, which is why it is like doctors everywhere, but it's beyond the reach of this population. Okay. um just coming to the third point that I want to make, this point is linked to the epidemiological transition that Vaibhav was talking about. There are more chronic diseases coming in, and chronic diseases imply that people have to purchase medicines for a long period of time, not like cold, cough, or fever, when the family could shell out extra money temporarily. They could somehow manage the extra cost. Chronic diseases means chronic costs, long-term costs. And because of this, people had to strike a balance. When do I need more relief? And when can I afford to spend more money? And they often compromise between these two. And because of this, there is poor adherence to medicine. They don't always listen to treatment advice that is given to them. Okay. The final point I want to make comes back to the to the weak primary level public health system. So Vaibhav had already introduced it, the system. So in India, we the public health system we have is supposed to have three tiers. The first, the very base of the pyramid should be the basic primary health care services that we have. Then we're supposed to have more specialized services, and then comes the tertiary care. Okay. uh, in urban India, our public health system has evolved in such a way that the primary level, the very base of the system, is very weak. And because of this, in many places in urban India, it's the tertiary care hospitals, it's the big hospitals, which is also serving the role of a primary care system. So it's also serving people for common ailments. Okay, and this phenomena we technically call as bypass. So if we go to, say, AIMS New Delhi, or Nair Hospital in Bombay, these are tertiary care. These are tertiary care institutions, but we not only find very advanced cases here, but we also find those who are coming just for general outpatient care at these institutions. Okay. My last point is, of course, in the recent years, people have recognized this. There are efforts being made to strengthen the sort of base in the system. We have urban health posts being set up. We have the innovations like the Mohalla Clinic in Delhi, and there is general awareness that we need to invest in urban health services to improve access. But I think we still have a long way to go before we are able to make access much easier for these populations here. So I'll end here. Thank you so much, everyone, for listening. And in case you want to engage with the case story more, please feel free to drop in more comment. Looking forward to your thoughts. Thank you.
Thank you.
Over to you.
Thank you very much, Sudha. And just be with us. Yes, we may have some questions or comments that you may want to engage with. So thank you, Sudha. And I think with that case study you highlighted, how fragmented our healthcare delivery systems are in urban areas, and how complex they are really. In fact, in Bangalore city itself, there are at least 7 different government agencies which directly deliver healthcare services, and then of course you have a heavily commercialized, very dominant healthcare system. And so I think you really point also to this larger planning and governance challenges when it comes to urban healthcare systems, which are clearly not equitable, and probably not serving those who need it most. Um, while that remains a challenge, and I think you highlighted some of the recent initiatives towards at least strengthening the primary healthcare systems. I think we have to keep in mind that healthcare systems themselves are just one of the social determinants of people's health. In fact, Amartya Sen used to say that, healthcare systems are illness care systems. People come there when they are ill. That's not how health is generated. That's not how health is created. And so health is also fundamentally shaped by many other marginalities. And I think that's where I like to bring my friend Aruna. Aruna is a medical anthropologist, and has traversed the worlds of the healthcare systems, the working with marginalized communities. Currently works here at the Indian Institute of Human Settlement, Bengaluru. Aruna, help us see these other vulnerabilities that shape people's health beyond just being able to access, whatever weak urban healthcare systems they are there out.
Thank you, Ben, and thank you, Vaibhav and Sudha, for setting the stage. So I was just thinking, listening to your how you're kind of carrying forward the conversation on transitions. So I would be a bit reflective. I probably would not really use any data or framework or theorization, though for the benefit of discussion, what largely I'm going to discuss, or the kind of framework on which I think me or Prashant and also going forward Upen would discuss would largely fall on social determinants of health, which we often go and hide behind them. And it's also how we position health at IIHS, because we, like I was mentioning in our previous session this morning on health transition in the urban, that there is also a certain positionality that we have chosen to take, because there is also a way of studying health or understanding health through biomedical, clinical ways, which is not right or wrong. I'm not getting into that debate. However, the moment that we get into the rights perspective or the rights based approach, we look at citizen, and their rights and the basic rights that a state has to provide. Health comes there. The health discussion on health at IIHS stems from there. So the way we are using social determinants of health are also tied with our discourses on the around city, how the urban spaces are changing, how housing, for that matter, where people are living, where they're working, and everything is tied together, and health as an outcome, hence, is what we see in the terms of health outcome. For example, we can use the word illness, sickness, disease. Again, pardon me, I am an anthropologist, so I would always like to use this kind of terminologies to explain disease, or for that matter, health outcome. And that is oftentimes very problematic when we also discuss systems, because systems thinking is also a complex way of complex knowledge, for that matter. So that is what I was thinking, like how I'm going to talk about or explain this problem or the problematization that we are kind of dealing with in the urban. So in my reflective way, I was just thinking, the first time I stepped out to do a data collection or understand what ails or what is happening in the urban slums in Delhi was through the lens of tuberculosis. And then I remember the whole, because, when we talk about transition, there is always a force of transition. We have to also understand that. So the common conversation, like, oh, there's so many slum dwellers, and it will also increase the number of slums in Delhi, that kind of discussion in the city. I'm talking about 96, 97, that kind of a time period. Because DMRC, that is Delhi Metro, we were actually, the whole city was kind of becoming an excavation site. So and I also would like to tie what Aro was mentioning in our in his opening remarks, that how we seek this transition and how each of these parts of the systems are constantly changing. So the knowledge base of those systems and the parts of those systems are constantly changing. So the moment we say marginalization, for that matter, moment we say migration, where do we stop and where do we start? Like many of us, like I started, the population science, like how we deal with understanding demographic pull and push. And so to understand the human transition, Assis Bose, I mean, the famous demographer, would we still get stuck with that kind of explanation? Maybe if we look at how the city of Bangalore and how we are constantly seeing migration and understand the pull and push of migration in the city, probably will like to change that. So I am not going to, I mean, of course, we are simply sounding, simply probably problematizing, probably not really finding any solution, but we're also showing the interest that we need to really work and work probably in an interconnected way, much deeper, and not get stuck with one particular knowledge just because it worked or that framework worked. But so coming to the point of the problem or the challenges that I find myself doing public health or doing health systems research for so many years, that why there is no solution is also very, a point of disillusionment, so to say. So as a researcher, how much are we also transitioning or creating transitions around us or allowing transitions around us for a fruitful answer? So that kind of reflective frame I am kind of getting into. But so to say, I would also like to maybe go to the framework, and even if our colleagues are interested, we can read this. That I remember in one of the discussion in the morning, we discussed NCDs. Even Vaibhav mentioned about epidemiological transitions. So they are not happening in vacuum. They're happening because cities are also changing. The ecosystem around the cities are changing. Food habits are changing. Not because we want to change, because it's also a part of supply chain. It is also a function of economy that we are in. Suddenly, affordability is, nobody's studying that. And, and also there is no cookie cutter way of understanding that, okay, urban slums operate this way. I can vouch for it that if we study 5 urban slums in a periphery of 5 kilometers, we will see different trends, different consumption pattern, different out-of-pocket expenditure. So, I'm actually very startled, and also this is probably the way I would like to summarize, saying, so where do we start? If, like in Bayesian philosophy, I'm sorry, I'm really sounding very confused, and probably I'm not really coming from one stream of thoughts. So they say that we can fix a problem if we can create a constant. But if everything is moving, how will you fix it? So I actually see a corollary in this kind of, it's a kind of that kind of a situation. We know health systems enough, so to say. We understand epidemic or epidemiology, so to say. We understand social determinants of health, so to say. But every parts of the puzzle are moving. So I see that kind of a thing if we ask me to comment on transition or in the urban and urban health systems. So somewhere we have to really freeze something and then say, okay, let's create a standard, or maybe we create an utopian system and then see how that can be, or maybe a small micro system which is really ideal, and then say, can we then see where are the gaps in other urban settlements or informal settlements, or those kind of linkages, because we know enough.
Yeah. Well, thank you. Thank you for confusing us. It's good to be confused, because for long we have treated health systems and the production of health in a very simplistic and reductionist way. Maybe because many of us purely came from medical, dental, health background where our training was of that kind. I remember 20 years ago when I wanted to study public health, I was not given admission here in public health courses because it was reserved only for medical doctors. You can think the height of it. And I'm glad that we have come to a point where public health is shifting, in a sense that the knowledge production has gone much beyond the hands of just the medical and paramedical dominance to several other disciplines, and I see that as a pleasant sort of transition. Hopefully that will show us the way. Maybe I'll go to Prashant. Uh, Prashant has been a colleague at Institute of Public Health, currently director at Institute of Public Health, a very good friend. And when I met him first, he's also a medical doctor who initially practiced in the Adivasi areas as a medical doctor before transitioning to public health. And I think when I met you first time, you had more publications about birds and ecology than about health. And I think I really treasure his journey, where I think much of his work in last decade and a half has really been core social science look at health of people, with very strong grounding in Adivasi health and understanding the Adivasi identity, what it means. In fact, we had, I think, I don't exactly remember the year, but we had the opportunity to release a book. You're one of the author on health inequities in India, where many of you had synthesized the available evidence in in this very room. So over to you, Prashant.
Thanks. So I think thanks, Upen. But my health publications have now outpaced the birds and ecology. Although I wish it could have been the other way around. But let's take the challenge of the framing that Aruna brought, which I don't know if you will disagree with me. It was a bit disabling to hear. If it is so difficult to take on the challenge of urban health, if everything is so changing, so dynamic, so then what do we bring to the table through knowledge production? So purposely, let me start by challenging that. And I'll come back to this. Let's take something simpler. Okay, if health is so social, and I think we'll all agree that health is unfairly distributed, even healthcare is unfairly distributed. Forget health status and health outcomes. Healthcare also is inequitably and unfairly distributed in society. But apparently, because we have such a large number of public health professionals, medical colleges, etc., if we take healthcare in the urban context, if we examine how do we do with that, um, I feel it might be simpler, and let's take that. So I feel what panelists have been saying about rural versus urban health, like what you said, I think the rural health, if we just crudely simplify it, what is the overriding principle on which we have designed rural healthcare? It is that rural population, I'm now stereotyping crudely, rural populations tend to be low literacy and they are living far. So we have to take healthcare to the doorstep. That's the kind of thinking you see in rural health. So then you have an Asha, and then she invests in, telling people how to live healthier lives or whatever. In urban health, the underlying principle has been, okay, healthcare is, lots is there, but it is unaffordable. So we have to somehow make the financing better. I would argue, even if we oversimplify it to these two also, I think we have even there failed, even if it's not so dynamic, right? And I think the failure for me is, I think, a lack of imagination of healthcare, even forget health. We've not been able to imagine healthcare as something that is deeply personal, that is deeply also somewhere, at signaling issues of trust, dignity, and that kind of thing. It's been looked too much as something that ought to be just partitioned better. So how do I just give it, distribute it better? So partly I think that's the problem also in urban healthcare delivery. So I mean, since at least two of us, even you have backgrounds in rural Adivasi remote settings, how is that connected to the urban space? And one clear connections I see every day, because last, I think, 6-7 years we've been doing a long-term learning site in an Adivasi setting, which is about 200 kilometers south of Bangalore. Severe livelihood stress, social stress, pushing people either to harmful health behavior locally, sometimes even intergenerational stress, or pushing young people to cities, right? And even in that context, if you're a young adult, typically male young adult, sometimes also several women too, who migrate for work to cities, you are in a situation where your partner's maternal health is being taken care of an Asha somewhere in your village. If you have a severe injury that requires long-term care, you have no one here, so you go back to a rural health care. Or, of course, if you can afford, you try to go to a big hospital in a city. And I think despite the Ayushman Bharat digital mission, the digital health stack, the Aadhaar, which provides a framework, theoretically, we can provide continuous care. It's not so ideal to imagine for a moment, if you leave aside the Aadhaar requirement and arguments about it, it's easy to imagine that somebody from BR Hills is living in Bangalore, has come for typically hot chips. Many people come to make chips, etc. He gets diagnosed with tuberculosis, let's say at a nearby PHC, and then it's possible that if he goes back, information is transmitted because he has got all the digital identity, etc. This is what was promised when they said there will be a digital health stack, there will be a digital mission, etc. So even that we haven't delivered. It's not happened. It's forget. And in the case I'm talking about a person who has come from a remote rural area to Bangalore. Let's say, okay, between aims, let's say I've gone to Delhi as for some reason. I'm from, let's say, a small town in Karnataka where there is another aims. Between aims, you do not have portability of records. So I think the framing that lot of this problem is because health is so complex, I would like to challenge that. I think even the simpler aspects of healthcare we haven't dealt with because of a leadership, imagination gap, governance gap. I'm also struggling. Why? But I just wanted to.
Yeah, thank you, Prashant, for highlighting the lack of imagination. I am reminded of the time we need to open up for exchange. But yeah, maybe I'll take a couple of minutes before we open up. Not that I'm a panelist, but I just wanted to bring in a bit different angle. I think we heard in some detail about how social, cultural health is. And of course, not just that. I think we had a lot of intersectionality being discussed here. But I would like to highlight one part, which is how businesses shape health. And I think that is becoming more and more important. Not that the businesses are new. I mean, probably the commerce has been pervasive across ancient societies. But I think the way you see how under capitalist system that we all live, how businesses have become dominant. I was just looking at the states, and if you look at the first 100 economies in the world, around 60 are businesses. They are not the sovereign countries. And if you think about 200, more than 150 are the businesses. And you can imagine what kind of power they wield, right? And lot of connections between businesses and people's health and health inequities. And I think I'll just, this is something that we have been theorizing for last 10 years, what we call commercial determinants of health in public health language, where we are going beyond just the difficult products. I mean, earlier we used to work on extractive industries. Tobacco, yes, it is bad, but that's not the only way businesses shape people's health. Businesses do a lot of other things which are not related to the products and which have very direct impacts either on public health policies, and that's why on public health, direct impacts on employees' health. I know some of you work in labor studies and you know it much more than me in terms of how the employment related conditions, the work shape employees' health, but also the larger factors beyond business entities. The fact that there are certain features of this mode of economic production where wealth maximization is the goal, and it can easily come at the cost of, let's say, natural environment. It can, where the labor can be treated as a disposable resource. Many of these, where very valuable roles in society, including caring for health, is not valued enough if it is not leading to wealth production, has a problematic impact on public health. And I'll just highlight some examples to revisit all these arguments, because I think Vaibhav was highlighting the epidemiological transition where we have rising burden of non-communicable diseases. And it is true. But if you look at just 4 commodities, tobacco, alcohol, ultra-processed foods, fast foods, as we say, and the fossil fuel. If you just put these 4 things together, which are consumable commodities, they explain about 65 to 75% of deaths globally resulting from non-communicable diseases. Now you can think, what is the role of health system here? Yeah, are we even doing anything about it? Then recognizing it as one of the risks. It's not even within the remit and power of health policy makers, and that's where I think we need to start thinking beyond health systems. Access to healthcare, I think we heard from Sudha, but also it was a constant theme in terms of difficulty in accessing healthcare in urban areas, but also in other rural and tribal areas. But we often don't talk enough about the way healthcare has been commercialized. Yeah, I mean, in last 2 decades, even the corporatization of healthcare, if you think of it, if you step into any private hospital, probably the first question you will be asked is, do you have health insurance? Right? That's the first thing they ask us. And I think I wonder, what is it? Is it that somebody is worried about the financial protection of me? What is it about? So yeah, I mean, the healthcare has become a commodity, basically. And since we have gone down this route of insurance as a tool to provide financial protection in universal healthcare, it has taken its ultimate form. You have packages. Health is itself is no longer a kind of a continuous sort of a care. It's rather commodified. And then there are various social transitions. We don't have time to really go into it. But advertisement, we are discussing how social media is a big determinant of mental health. But by the time we'll even, wake up to it, it will be impossible to deal with it. I have worked on tobacco for several years. Social media platforms are extremely addictive, more addictive than any of the psychoactive substances, right? And the housing and real estate, I think some of you highlighted, the problems of it. In fact, one of my good friend Rupa Devadasan and team, they work with Hakipiki Adivasi and other rural communities in Bangalore. They live in Bangalore, and you see one of the common problem they are facing now is that you have large infrastructural projects, gated communities coming up in the outskirts near the Banakata Park, also the extension of the outer ring road. And so many of these communities had small land pockets. They are all being sold. And it is converting into a very cash-based economy, and you suddenly see alcohol lobby coming in and shaping the whole health scenario very differently in a very few years' time. So it's not something that takes a long time. Of course, labor and employment, we mentioned how the precarity of labor in large scale industries. And I just returned from Delhi, where it was a commune on business and human rights. So businesses are being forced now to transition to sustainable future. But if you look at it, where are the major investors, consumers lie is in largely in global north. I'm stereotyping, of course. And where are the supply chains, which is in global south? You buy a very fancy brand of cloth, and it's more likely that women garment worker would have stitched it in streets of Bangalore. So when you talk about transitioning in terms of green energy, where the cost lies. So I think they are already now talking about decolonizing these debates around, and I think that same debates are there in public health. How do we decolonize global health, public health? But I think importantly, it's not just decolonializing. I think for us in India, it's about how you decaste, how you degender, right? That we have many more things to sort of transcend. So I think with that, hopefully, I think with these wonderful inputs from my panelists, we at least highlighted this very interconnected and dynamic process of, it's not one and the other transition. It's how various things are sort of evolving. Health system themselves are evolving over time. So I think now let's open up. We have time maybe up to 7:15, if I understand. Yeah. So okay, I'll keep an eye on question answer online, but let's start from the room. If somebody wants to have any comments or question. Yes, I already see Divya raising hand. Please raise your hand so that I know. Go ahead, Divya.
I have many questions, but I'm going to stick to two of them. One is, just coming from the other side, not talking, going to health as an outcome and not so much as an entry point. There is a lot of conversation today about pushing the female labor force participation up. Fundamentally, the biggest problem that we're all talking about in labor studies, right? And yet, all those jobs are in very precarious environments. The problem I'm sort of, trying to engage with is not the fact that health is gendered within the household. There are differences in whether you treat the male member versus the female member, but the state itself being very gendered in its expenditure towards health outcomes. So, for example, maternal and child health would get all the focus, but women's health otherwise, outside of maternal and child health, doesn't get any attention, right? So, I'm just trying to sort of think about where does labor, employment, you mentioned it, but if you look at all the frameworks that have come so far, commercial determinants has it as one broad thing, but considering that we are talking about all these kinds of transitions, where does labor sort of fit in within any of these frameworks? And one last question, also thinking about what does this mean if we are looking at a society where earnings are important to be able to access health, but the earning is happening in environments which has completely eroded or degraded your body. So the question of dignity that Prashant was also talking about. So are we just circling back then? Is it a chicken and an egg problem?
Yeah, I think just because I'm back from that forum, and we had a lot of, I had the opportunity to hear so much from the workers and the people who work in labor movements, and I can completely relate with your concern that I think while we have occupational health and safety as kind of legislated kind of rights within the labor code, but if you look at it, I mean, it's all about physical disabilities, injuries, and things like that. And I think the women whom I was listening, whether it is garment work, whether it is sugarcane fields, they're talking about constant mental stress, and mental health is completely absent from that labor health discourse. Of course, there are many more problems, but there are obvious gaps, and some of these are replicated in mainstream health system, like you say. I mean, uh, in Bangalore, when I started studying health system, it was all about maternity homes, which are still called maternity hospitals, so BBMP. So yes, if you are a mother, if you are pregnant, then you have health services, but you, as if you are not a woman, and then what happens with all other things? So yeah, please come in, Prashant. You want to come in? Yeah.
I had maybe I won't attempt to provide an answer to the issue of how labor is framed within health policy, health systems. It is definitely marginal, that I accept. But one talk I had recently heard is someone explaining, this is outside my area of expertise, but they were explaining how macroeconomists are using this race to the bottom framework in governance, saying that in an increasing world where states, provinces, cities have to demonstrate productivity, you will only have a race to the bottom, because investment in labor means that you are sort of privileging things like dignity and that kind of stuff, which is not costed. There's no short term gain. So it's a little bit of a bleak picture for me on why would, like, let's say in a scenario where BBMP or city corporations are given the decentralization space to reimagine their urban health care, will they be investing money in these kind of things? I don't know, and how to do so. I think I invite all of us to think about this. Is a very important thing. But the second question on we live in a health system that you said is dependent on income or having money, but apparently not. If you look at the documents, at the, like, if you see the intent of Ayushman Bharat was this was the problem it was supposed to fix. It said, okay, people are having high out of pocket expenditure, so here is there are two arms of Ayushman Bharat. Without going to details, one arm is entirely to reduce out of pocket expenditure. Is it working? Is it really creating then a system where if you do not have income money at the point of service delivery, are you still getting good enough care? It's really not, right? So what went wrong? Was it a design flaw, or are we these are the kind of questions I think we must be investigating. And a very one other, is there time for one quick response on
Yeah.
the thing of if you I'm just running on this hunch that in an ideal scenario, panchayats, districts, city corporations, all of these, as far as the legal framework is concerned, have the financial powers and other powers to say we want to, and they have revenue, so they somewhere I feel there's a fail. That's why I said imagination. So I don't think we have said we have create we all of these are looking up for, okay, what scheme, what kind of national mission will come and solve this problem. There does not seem to be sufficient convening at districts, panchayats, or city corporations to say, okay, Bangalore has a problem with unfair healthcare. What can we do? We are all waiting for a mission to fix it. So I think that's where I feel the problem is.
Thank you for asking that problematic question, Divya. So I was just kind of, and also thank you for setting, because otherwise I wouldn't have come in now. I've been thinking like this, and also it's not again providing any solution, that there are pulls and pushes. Like our health systems are also operating as a function of demand and supply. So how much are we also creating? When people are moving, for example, there is this economic pull that people are coming here for jobs. Are we disempowering or empowering? Especially when it's a basic right to like you said, that we have the database of knowing how many, who are moving, where all. But if that is not being used, that means that whole tendency, like it will be done, it will be provided by the state, vis-a-vis, can we think of empowering people to some extent? That's exactly the reason I was using, or maybe I didn't explain enough, rights based approach, because we cannot think of creating a system without plugging the ways of accessing those systems. So what happens here, like we say, oh, like I can take example of tuberculosis for that matter, or PDS system for the other portabilities of, say, any continuum of care. We do not imagine things are moving. Oftentimes, the denominator with which our systems are working are static. Even intra-district, intra-state are missed. And now, if I'm problematizing with language, people are oftentimes not aware that they can access. They have the rights and they have the, the right to services in another place. So oftentimes, the questions, do you have residence proof? And they just go back. Even if I don't have residence proof, I can show my number, and you can link that in different states we have this mother and child card. I don't know in Karnataka what is the name. Thai card, yeah. In different states we have different names. So the programmatically it is a very novel things, but the moment we see ourselves as labor, for example, an informal worker, that is very disempowering. So I'm also thinking of that function of demand and supply, because system is also how we create. So I do not really disagree with any of the questions, but again, I come back to my disillusionment. Maybe
Yep.
I get my solace there.
Yes, please go ahead. Yeah, here.
Thank you so much for your the panel discussion. I learned a lot from the past 45 minutes. So, how do you foresee the future of ASHA workers and Anganwadis who have lots of responsibilities at the moment? In the coming years, in the coming decade, like what do you think of them in terms of future vulnerabilities in rural health, and to an extent out migration from rural areas?
Yes, I see Sudha raising hand. Thank you for highlighting that. I think health system themselves are to be blamed for a very gendered labor kind of workforce, which has not been given its due. So over to you, Sudha. Please unmute and come in.
Yes, thank you, Ben. Uh, yes, uh, I think this is a topic really close to my heart, which is why I said let me jump in. As a researcher, I always feel that a lot of research has been done on community health workers, whether it's ASHAs, whether it's Anganwadi workers, always in the rural regions. Okay, we've even if we haven't got the implementation of this right, okay, but we've got the model, the design of an ASHA worker. We've gone through many sort of frontline workers in rural areas, and we have some idea of how this person should look like, how what kind of incentives should they give, and how do we implement it. We do have some idea of this. When it comes to urban healthcare, I always find this missing. Okay, and this, I'm speaking from my work in Bombay and some other some other urban parts of Maharashtra. We don't have a urban community health worker model. We've tried to copy the rural model into the urban, and we've tried to modify it a little, but it. My sense is it's a lot more difficult. A lot more thought is needed into who would be a good community health worker, or can we just replicate the same ASHA model in an urban setting? That's my thing. So just for just one example is that in a rural area, I can say, okay, this is the language of the ASHA. She belongs to this community. This is the kind of language she speaks. She can sort of mingle with the community much better. But let's say in one area in a rural slum, I have five kinds of languages being spoken. I have four migrant population from different communities. Then it becomes a question: okay, which language should this Asha speak? So even which community do I choose her from within that little pocket of urban population that I have? So right from this, we need to see what needs to be done. It's the same thing with ICDS. So Anganwadis in rural areas are beautiful spaces. They have nice angan. They do have a garden. They have a nice place. But if you go into an urban slum, it is usually a rented building right on top of uh, the second floor of a house where they can afford a rent, where the children can hardly reach. During the rains, it's very difficult for people to climb up, to leave children there, and it doesn't remotely resemble how we sort of imagine a play school to be. So those are challenges that we haven't thought about and definitely needs more work. Thank you.
I had another question.
Go ahead.
Yes.
Please.
For some time, I think even policy documents talked of an USHA, an urban social health activist. And the running joke at the time was there the Asha for rural and the Usha for urban. Will there also be a Sandhya? Because Sandhya is the dusk and the anyway. But again here I come back to that point. Let's imagine an urban Asha equivalent in cities where we have outsourced public services to small private spaces. What would be the acceptance of a universal urban worker in gated communities, for example? Um, let's say we fix a salary for this urban Asha. Will someone living in that gated community potentially then sign up for that salary to be a community health worker there? So then do we have to then say, okay, rich people get a higher paid health worker? So it's very bizarre. I think we really have to, in cities, really have to reclaim public health into their cities, because I think right now what's happened is it's completely left to you. You are figuring out, we are living in the same city but navigating different forms of health care and having different health environments, even if we are neighbors. And like Divya was saying, maybe even within families we are having very different social environments. So it's a very vexed issue, and I think I don't know how cities should do it. And I think the urgent need, maybe they should start, maybe some wards should start, because wards have the capacity under the legal framework to say, okay, in our ward, how shall we add something to what exists? And I think that kind of thing, decision space, they have not claimed. Wards have not claimed. Cities have not claimed.
Yes, Divya, you want to come in?
So I was just wondering, Prashant, are we also being extremely conservative about where health should be delivered? This, like the rural where we think home and the communities where healthcare should be, considering migration, considering epidemiological transitions, are we completely too scared and conservative about engaging with employers? Why is still home the point of delivery when people are spending 10 to 12 hours across classes at the workplace? And this goes back to those older questions on insurance and social protection and all of those. I'm keeping that aside. But even in terms of engaging with employers who are a political force. So have we not come out of this? I mean, have we become so settled in our frameworks that we have become conservative because we haven't changed them? I mean, I've been studying social determinants of health since I started my PhD now, which was many years ago, right? Have we not sort of kept up with times?
No, I think it's possible to. These are the kind I would say we have to lacking of imagination. And I was saying, for example, in cities, employers taking much more responsibility could also be a way of addressing, commercial kind of what kind of workspaces are you providing, creating, etc. That's true, and that I agree. But still, even if you would do that, the idea of a health worker is not only healthcare delivery at doorstep. But the idea of health worker in the primary healthcare framework was a person that a specific set of community relate to, and he or she then also binds. And it's how do you explain? Like, I mean, like an ASHA for a village is their ASHA. It's their my public health service. This is how I connect with. Cities do not have that. We all have our private health services in one way or another, and for COVID vaccination or for some that kind of a thing, we all then have to go to that BBMP center or whatever. So there, I think even if we fix employers' responsibility, we still have to fix health worker and community engagement in health in cities, I feel.
Yeah, I just a few quick comments. I think I agree. I think we must explore new ways of delivering healthcare. We are also a bit caught up in our own frameworks, so much caught up, and I think it's a bit of an epistemological hegemony, that we are so caught up we don't even consider families as a level of health system. How to Our budgets are all about first line care, referral care, and things like that. To an extent where a lot of government initiatives even today plan themselves as if private system don't exist, as if we don't have to connect with private system. And then all of the other things. But I think when it comes to employer, while I think it is very promising to explore it, but I also have doubts because one is the informality. I mean, we do have some frameworks, right? ESI and other ways in which workers have to be registered and have to be provided care and have to be covered to an extent. But that kind of formal registration is very limited. And when this transition is happening, my worry is, and this is also what I sense from others, is that, I was hearing to an MSME owner from Tamil Nadu who owns a small garment unit, 150 workers. And now, if he has to compete, what he need to do is to do solar energy, is to do waste management differently. And this is a cost in already very competitive market. And unfortunately, many of these cost of transition will come at the cost of the employee's pay, which is very unfortunate. And also, I was also hearing about ESI. So while a lot of workers were registered with ESI, some were not, of course. In automobile sector, many workers are yet not registered. They are completely invisibilized. But even those who are registered, what I commonly heard from them is that either they are not issued ESI card, or many of the workers, when they got injured, they were the employer facilitated their care in a private hospital, not an ESI hospital, partly because ESI was also not around, but also so that this whole episode remains private. Things don't get reported. So I think with an increasing emphasis on human rights due diligence, disclosures, my worry is that this transition may not be just. It's another unjust transition. So I think we all will have to amplify our voices to say, how do we make this transition more just? Yeah. We have time? Yeah.
I think she has a follow-up.
Yeah. My question was, how do health systems and clinical care and even public health administrations in India incorporate indigenous or other subjectivities into into health delivery? And you've worked with Haki Paki communities and Adivasi communities, so I'm just curious how that works.
Prashant? They both have worked quite a bit
More.
with Adivasi communities.
I mean, in terms of organization of care, to give an example, based on the population norms are fixed. If it's a non-indigenous population, then it can cater to more population, one facility, right? But if it's indigenous or tribal population, then you have to, the norm is I mean, lower, so that they can sort of provide care in a better way. That is one way. But beyond that, I think largely, if I stereotype, our health system hasn't been able to really cater to the requirements in various ways. Socio-cultural, be it, it's sort of lacking. For example, one of the constant themes you can always hear when you interact with community, whether it is indigenous or non-indigenous, is that they lack trust in the system. They really fear going to a and especially in tribal community, if you have to refer to a woman or even an adult male, that please go to a primary healthcare center or maybe higher center and get further care, they would hesitate because they don't have that trust, because the system hasn't really worked with the community and sort of taken on board the requirements that need to be thought of. But if you want to highlight, yeah.
Yeah, I mean, on a very daily basis, the hospital we work with, a small tribal hospital, struggles with this, with the ability to, even despite Ayushman Bharat, we say, okay, it's all free, and assuming the patient has an Aadhaar card and the ST certificate, everything is free, the NGO will give you the ambulance. There is a fear and a lack of wanting to go to the district hospital, forget Bangalore. On the other hand, the willingness to go to a traditional bone setter. I'm talking about a young girl who fell from a tree recently with a hip fracture in deep pain. The girl herself and the parents said, please do not, they, with folded hands, they said, please do not send us to the district hospital. We are going to that guy who does traditional bone setting. He's good. And so I think to come back to your point, how do we integrate these into health? I don't think we are even trying. We are not even trying. There's a huge number of traditional providers which are catering snake bite. Karnataka was one of the first pioneers in making snake bite a notifiable disease. The underlying hypothesis is, oh, now that snake bite is notified, it becomes more visible and we can act on it. But how many people with snake bite are reporting to modern medicine centers, let alone government or private? Many of them are going to traditional healers and practitioners. So I think we have not been able to create a practice framework that allows conversation, respectful conversation, even if I don't agree with whatever the science and evidence base of the person. The fact that somebody is respecting him or her much more than my scientific system means, for practice sakes, I need to work with them. That kind of integration of thing, there's a lack of practice frameworks to guide action, I feel. But maybe there are other places where this is happening better, but I'm not too aware.
Yeah, Arun, I want to come in. But I just wanted to say, I think it also says something about health systems, how we have failed to provide culturally acceptable health systems. I'm sure not all of them. We're just worrying because they don't. I think there is also some prior experience because of which they have been really put off. They don't want to go to these buildings where they don't know how to navigate it. They don't have people who relate to them.
No social networks.
No social networks. Yeah. So I think there is also something fundamentally wrong in the way we have made our health systems. Yes, Arun, I want to have a quick interaction.
Yeah, I just thought of adding two examples. Again, not really directly coming from urban health systems, but I remember being part of, I'm taking names, UNICEF's fortification program, that too particularly looking at tribal groups in Madhya Pradesh. So just for a context, Madhya Pradesh is the producer of that's the number one producer of vegetable and wheat in the country. And we are studying anemia. And if we look at India's statistics, this is the state which is again at the top. So I'm just trying to create paradox, because understanding is that anemia meaning lack of iron enough or maybe malnutrition, and hence so that doesn't fit this kind of, like if I'm coming from a producing state, which is the largest producer, like we have data to support this information. And then anemia is also, we can look at NFHS and our census data. So that doesn't fit. And then we are working with very tribal group called Saharias. They're mostly working with other people's lands. So now the fortification drive is to give them some shortcut, like some laddus, and then not asking, like, sometimes, like how we are talking about rights-based approach, like health is also my concern. If I'm anemic because I'm away from my ecosystem, I'm also eating something which I'm not supposed to eat. We are also biochemically very different from each other. That nobody is discussing. And I am now force fed those fortified laddus and putting, like, my children are going to those SAM centers, SAM meaning severely anemic, hmm, severely malnourished children. And there are those special places where mother and the child has to go for 15 days, learn those recipes and do. So this is very top-down approach of fixing problem. The other problem that comes to my mind of integrate, like, because you specifically talked about indigenous, so I'm kind of juxtaposing this because oftentimes we do not understand each other's culture. Health system is also a cultural system. So oftentimes there is this whole hoo-ha about they are not knowledgeable enough. And trying to talk about integration, how we would also like to create the value of trust, dignity, also resources, because there is a certain group of, even us, we go and seek health in a certain way because we believe that it works. So there was this whole concept, I think is again a defunct concept right now, that informal service provider. We were trying those concepts way back in Orissa, in tribal districts of Orissa, that those Gaon Buras and Gunias can be a referral. Let them at least have, like three things, like, because this is a malaria endemic zone, you cannot think of sending people to, district level hospital or health center. So at least we need that point of care near where people are getting affected. So those kind of concepts, we're always questioning the other knowledge, other kind of knowledge, with a kind of a concern or kind of a doubt.
No.
And not integrating. So similarly, migration, talking about these urban systems are also, I see as a string of hierarchies, a string of,
True.
So I just thought of giving these examples to also think like what I should eat is also understood in a different way, in this case a Western way, or an urban way, or so these nobody's studying, or nobody's going in within those layers to understand that things are also falling apart because people are disempowered constantly.
Thank you. I think we have already hit our times. Yeah, the last one. Oh, sorry, I missed it then. Maybe we request, maybe I'll read it out. Is that how it work? Yeah. So currently within urban spaces, healthcare delivery from the public sector is focused on slums. Yet traditionally, trust and perception of quality of care in the public sector is low within this community. How should public sector move ahead within this context, especially Ayushman Bharat taking center stage? Who would like to? I know many times we have just further explained the problem than really offering many solutions.
If you push the panel for solutions, I think I don't know. I'm not speaking for all public health professionals, but I feel that public health community needs to learn how to do this, and maybe part of that learning is by using the fact that cities do have the decision space to imagine, right? So for example, in Bangalore, can multiple stakeholders come together and say, let's take a ward, and let's not go away from this dichotomy that public services are for slums and whereas the private sector is going where they want. Let's at least define a basic framework of what a healthy neighborhood is like. So I think we have to somehow come together, create some kind of a learning site, and then work with implementers and say, okay, how can we reimagine Bangalore's healthy neighborhoods? Have that kind of a campaign, learn how to do it in small scale, and make the idea go viral. That's the COVID time type of.
So for a change, I see Prashant is almost paraphrasing what I started with.
Okay, great. So, yeah, sorry, Diana, I don't think we have a clear answer to your question, but it also says about the state of, I think, public sector and public health within urban areas, especially because a lot of models and a lot of learning is so much about rural systems and rural areas. Great. So, I think thank you to all the panelists. They highlighted a lot of things, but I think I can see two issues as central. One is I think the discussion highlighted a lot of very specific gaps, and these are large-scale gaps: lack of imagination, systemic challenges in urban healthcare delivery systems. And the other one is, of course, I think it's very obvious that how health is so much about other things than just the medical care. And I think in that way, I'm so glad that IIHS is hosting a panel on health here. And I hope that this only becomes one other avenue where many of us work across. Yeah, labor studies. I think public health ought to be that, and I think it is slowly becoming that. So that's the takeaway. With that, thanking all my panelists, I would like to close the panel. Thank you so much for all your time.